It is my great pleasure also this year to be part of this great event. I'm Roberta Maselli from Milan, Italy, and the topic of this year is how to manage complication in space endoscopy. So starting what is space is the space, let's say, between the first and the second. Is the first space the luminal space, the space we are familiar with. Every endoscopist stay usually in the first space, and the second space is the one we want to avoid usually. That is the surgical one, for example, the peritoneum or the mediastinal cavity. The third space, let's say, is everything is in between. And with the new procedures that nowadays we can perform, like, for example, POEM or Z-POEM, and Professor Seti, after my presentation, will talk about all of this. We know that we are using the third space for our new procedures, but all of these very advanced techniques that carry a very higher risk than usual of complication. And this is why here we're talking about safety. And mainly we have bleeding, perforation. They are common also to other endoscopic procedure, but specifically for ESD interspace, we have the post-polypectomy electrocoagulation syndrome that we used to call for ESD, the PEECS, post-ESD electrocoagulation syndrome, and then we have also stricture. But let's try to have a nice follow of all of this. Start with PEECS. PEECS, let me say, that is the most common adverse event and is defined as a peritoneal inflammation in the absence of a real and frank perforation. And the patient presents with abdominal pain, fever, leukocytosis, major signs of peritoneal inflammation, but then you won't find on CT and X-ray examination any frank and real perforation. And the cause is, we think, is due to an excessive coagulation in the muscularis propria, and also to leave a mucosal defect that is exposed after EXD, for example. And it's so common that its rate can reach to 40% in colorectal ESD, whereas in gastric ESD is a little bit lower, up to 7%. So if we look at the guidelines, we said when we have after ESD or after third space endoscopy, a patient that is complaining for fever, localized abdominal pain, peritoneal signs, leukocytosis, and also reached level of C-reactive protein, we should have the patient stay in hospital to give him supportive measure, to observe, and then to try to understand with CT imaging if we have a real perforation or not. In case we have not, then we can think about PEECS, and most of the time just with conservative measurements, with antibiotics, nil per oral, and with intravenous fluids. In few days, the patient will stay in a better condition. And if we look at the prophylactic use of antibiotics after ESD to understand if this measure can really help us in trying to avoid PEECS. For example, in this case, they use in this randomized control trial prophylactic antibiotics before ESD in 50 patients with prophylactics and group 2 other 50 patients with no prophylactics. We see that the prophylactic use in colorectal ESD is associated with a reduced risk of PEECS. At the same time, some other meta-analyses and in the subgroup analysis, only cases for ESD did not show a significant effect. And this is why in the latest update of the ESG recommendation for ESD, there's no a clear recommendation for antibiotics before ESD and third space endoscopy. And now let's move to bleeding. You know that bleeding can be intraprocedural, post-procedural, so we have a delayed bleeding or during the treatment bleeding. And the rate is different depending also from the expertise of the operators. Here, for example, we have a different rate depending if we are talking about Asian countries or Western countries. And of course, the Western countries has a higher percentage of bleeding because of different skillness and different experience. If we want to go deeply and trying to understand and to have risk factors for delayed bleeding after, for example, colorectal ESD, we see that we have different factors. Most of the things is the prior use of antithrombotic agents, but also the resection size, because the bigger the size of the lesion we are trying to resect, the higher the chance to have bleeding, but also the morphology of the lesion, because the cell type has maybe much more vessels in the submucosa than can bleed, corresponding and compared to a flat lesion. Here we have the GIS-RE2 classification. This is for the risk to try to stratify and to understand the risk of bleeding and also delayed bleeding after a procedure. This one for the Spanish Society of Endoscopy. And you see here that you have 4 main factors. That is the patient status. So you have comorbidities, lesion size, because we were mentioning that the size of the lesion is impacting and affecting the risk of bleeding, but also the location of the lesion, if it is proximal or distal, and right colon ESD and in general resection have a higher risk of bleeding, but also the use of anticoagulants or antiplatelets. Here I want to show you that this is from Japan, they tried to take some measurement, prophylactic measurement, to try to avoid this risk. And they tried, for example, with this PGA sheet to put on the resectional bed after the procedure. They tried with mucosal defect to close the mucosal defect, or, for example, the second look endoscopy, and nothing is really affecting and helping us in avoiding this complication. Only for in the gastric ESD, the using of vonoprazan instead of PPIs. But for example, in Europe, we don't have this type of medicine, so we have to wait until it will be on the market. So let me say that still prevention is the best treatment, because if you know what you are dissecting and facing, you will avoid the complication. And usually we have these three main steps. That is detection of the vessel, preparation of the vessel, and only when the vessel is prepared, that means that you remove all the submucosa around the vessel, you can go there and coagulate the vessel itself. And I want to share with you this rectal ESD that is focusing on this step. So let me say that as soon I was in the lower rectum, so as soon I enter in the submucosa, I was facing the first one. The first step is vessel detection. So you have to inject nearby the vessel to prepare the vessel. So vessel preparation, it means that you are really removing all the tissue around to expose the vessel at its best. And meanwhile, you are understanding the anatomy. For example, this one was composed by 2 different vessels that was converging in just one. So I was finally coagulating just the single one instead of going for 2. And after the preparation, you then can go directly with the same knife in the center, not too close to the muscularis propria, not too close to the mucosa, to then simply and in a safest way coagulate the vessel, only the vessel. And then you will repeat the step: detection, preparation, coagulation. And most of the time you will be able to avoid bleeding and to manage the vessels without even changing the knife if you go in with a good technique. So, and this systematic review and meta-analysis, they also try to understand which are the lesions that they are really bleeding, and if the closure, the prophylactic clipping or no clipping was really affecting. And there was a statistical significant difference in clipping and not prophylactic clipping. So starting from this point, we should say that it's better to clip after a procedure. But at the same time, there are some others data reporting no difference. So even in this case, as the prophylactic use of antibiotics, we are in a debate, so there's controversial data, and still it's not so clear that you have to close all the procedure you are doing. But if we look, for example, here in the delayed bleeding was 8.2% in the non-closure group, and they had no delayed bleeding in the closure group. So, for example, this is the data that is showing that we should clip it. So again, we're still waiting for long-term data to understand how to treat this resection. So we were saying that still prevention is the safest ways to go, but when prevention fails, we must know all the endoscopic hemostasis techniques, starting from injection therapy, going through coagulation with grasping forceps, or even bipolar probes. Either probes, the clips, they are crucial, and you have through the scope clips or over the scope clips, but then remember that you have even something more. For example, balloon tamponade if you are in the upper GI and you are really facing an hemorrhage. You also have stents in case you need, and just remember that the new ones is the hemostatic gel and also the power. So depending on what you are faced, there's the right treatment and also the right device to use. For example, here we are in retroflexion in the transverse colon, and we have this putting vessel. This is an artery that is bleeding. So here the right way to go is not to put a clip, but maybe is to use the coagrasper to try to catch exactly the vessel that is bleeding. Wait, and when you are sure that you clip it, you can just apply the current and you're done. Move to perforation. This is really the trickiest situation and the worst scenario usually that you face when you have it. And the percentage here is very low in case of, let me say, simpler techniques like EMR. But when we move to ESD and third space, we arrive till 10%. And perforation means deep mucosal injury. We have the Sydney classification from type 1 to type 5. Type 5 is the full thickness perforation when you also have contamination, because the content of the first space, that is the luminal space, can go in the second one, that is the peritoneal or the thorax space. So coming back to guidelines, if you look here, we already start with the management, but let me say that the first thing is the pre-resection planning, the therapeutic planning, because prevention is always step 0. You should try to avoid your complication instead only on how and understanding how to manage them. So here we have a lot of questions. So which that means what about patient? What about the type of lesion? Where you are, it makes the difference, and we'll see anatomically there's a huge difference mainly in the lower GI, and then only at the end how to manage it. Looking at the risk factors, of course, as always, elderly patient with comorbidities has the highest risk of perforation, but also when you are facing a larger lesion or neoplastic lesion because of the neovascularization that they had. Fibrosis is a crucial point. I'll show you a video with perforation with fibrosis, but also, again, right colon and difficult and advanced procedure like ESD and interspace. So because the more aggressive you have, the more the chance you have complication. So as you can see, it's the same risk factors for bleeding. Let's talk about anatomy in the colon rectum. You know that there's a line that is the peritoneal reflection that makes the difference, because everything is inside the peritoneal cavity. Everything is down, is just in the rectum, in the pelvis, so you are a little bit safer. And it means that in the endoscopic resection or full thick resection, when you are in the peritoneal reflection, you must close it as soon as possible. It will depend on if you have end your procedure or not. Meanwhile, when you are in the real rectum, even the endoscopic resection can be done in a different way. So know your limit, and sometimes some lesion must be safer resected by surgical procedure, because we must admit that we can't do everything by flexible endoscopy, and we must collaborate with our colleagues. In the rectum, as I was mentioning, not all perforation are a real perforation because you are in a safe environment, you won't have the free cavity of the abdomen, and sometimes if you make mistakes or you make adverse events like perforation in the rectum, you can leave it there if they are very, very small and not very big, or even the closure is much more easier than in the colon. We were mentioning that the degree of fibrosis is a key factor for avoiding adverse events because as in bleeding, prevention is the best, and you should understand which is the right place to go. For example, here is clearly demonstrate where is the mucosa, which one is the submucosa, and this is the reason why we add the blue in the submucosal injection to always remember which is the right plane to go. And then you have the muscularis propria. But for example, here on the right, where are those space that we were looking and analyzing in the left image? And this is why they make also the classification from F0, that means no fibrosis, to F2, when you have this severe fibrosis and all the layers are really not recognizable. And I want to share with you what happened to us in this IBD-related lesion in the ascending colon. Was so difficult that there was no real lifting sign. We make the mark and we shift to EMR because we felt that it was not really safe to make ESD in this patient. The lesion was only low-grade dysplasia, so the injection was not good, no lifting sign. We suppose, because it was an IBD, a very high grade of fibrosis, but as soon as we start cutting, we saw a full thickness perforation, and we were working on underwater. We have no shift on CO2. We use that underwater to deflate the colon and to make no tension. And also we used that peritoneum that was coming, that fat that was coming on our first base, to clip it and to make the so-called omental patch. So once you have a complication, think a bit, wait, don't move, and try to understand how to manage what you have. In this case, we use the fat that was inside. So how to prevent? If the fibrosis is the key, other way, submucosal injection with blue will help you, but also have, and knowing your electrosurgical unit, always remember to have free mobility and to have a so-called one-to-one combination of your movements with the scope movements. And this was on EMR, but is fully applicable also to ESD and also to third space. And when prevention fails, again, you must know how to manage deep mucosal injury. The first thing is to minimize luminal gas insufflation, as I was showing in the video, and keep the field clean. If it's the case and you need, try to replace the patient in the good way to have a very good access to your perforation, because you have to close it, to try to close it. And then also, if it's the case, give to the patient any antiperistaltic agent in case you have a very strong peristalsis. Try to remove all the tissue. So it means try to end your procedure before closing. So don't panic. Otherwise, you only think of closing your defect and you will leave the patient with two problems. So one was the perforation that you closed, and the first one was the main reason why the patient underwent that procedure. And then again, you know your device, starting from fluoroscope clip to Otis to suturing devices. But I want to remember you that when you have the CO2 that is going outside in the peritoneum, you will have a capnoperitoneum. That means that you have to release the CO2 in the abdomen. And this is a very simple way to do, with a needle, try to puncture in the point when you feel with your fingers that there's a lot of CO2, just with the most tympanic area. And this is a nice way by attaching a syringe with saline to when you have bubbles, it means that you have CO2, and when the bubbles are gone and you see and you feel a soft abdomen, you have gone, and you will just remove the syringe. Again, depending on what you have in your endoscopic unit and mainly what you are able to use, what you feel comfortable with, you will go for TTS, but this will go for superficial closure for very small perforation. In the case you are able to use it and you have a not very big perforation, you would go for OTS. But then remember that if you are doing something really aggressive and advanced, you must also understand and have ready in your unit as the suturing devices. You also have different way in using and combine all the things together. For example, the use of the envelope is gained again from the past, a new life using together with clips and trying to close the defect. Sometimes you know from the beginning that what you do and what you will do will have a perforation, maybe not a full thickness perforation, because, for example, in this case, we have this big in the lower rectum recurrence after a previous several previous attempts of removal of this. So we were doing the ESD, just knowing that at the end of the procedure, we had to face with this type of problem. It was not a real full thickness perforation, but you know that the muscularis propria was somehow damaged and injured. So we used the overstitch to have a running suture, and in few minutes, you will see that with one single running suture, we were able to close all the defect in one time. So again, if you want to start and you're already doing advanced procedure, you must always know and be able to use advanced devices for closure and for managing complication. Last point is stricture. So most of the time we are talking about esophageal stricture, but let me say that even when you do colorectal ESD in a circumferential or almost circumferential way, you can face this type of problem. So for sure, when we look at the risk factors for postoperative stricture after ESD, giving and operating in the upper third of the esophagus is the main one, but then also when you have, again, macroscopic type that is bulging like sessile or a little bit excavated for the neovascularization, it could mean that you will injure a little bit the muscularis propria and you have this healing and the stricture. But also when you have a long lens, a longitudinal lens that is very very big or a circumferential diameter, you can have a stricture, and this is why you should start with oral steroid prevention. These are the Japanese guidelines for esophageal ESD, and see the main things is the lens circumferentially of resection. So when you go in less than half the circumference, there's no prevention, but as soon as you go for more than half, you will start with steroid injection or oral steroid or both together. So it's clear about ESD in the esophagus. We know also we have the algorithm to follow to try to prevent the stricture, but I was saying that it's similarly in the rectum, although it's not so cited as in the esophagus, because you know that, as this editorial said, the rectum is a more forgiving space, and the rate of stricture is modest, up to 11%. And again, it depends on the rate of circumferential extension. But if we look at the data, this is the Japanese data. They said that when you go for 100% of circumference, the rate is 71.4%. That is almost all of them. And I want to share with you also this European registry we made for rectal ESD. And on 130 patients, most of them, they had more than 75% of circumferential extension, and we had 13% of rectal stricture. Fortunately, all of them, they successfully underwent endoscopic balloon dilation, but in some cases, we must arrive till 6 or 7 sessions of different balloon dilation to arrive and to relieve the patient from symptoms. Really, the last point is trying to understand specifically how to manage complication in POEM. That can be a little bit different. And I want to show you some cases. This was a very young patient, 27 years old, with no comorbidities, type 2 achalasia. The initial EDGAR score was 7, but after the posterior POEM that underwent uneventfully during the operation time, in the first postoperative day, he had fever, 38.3, in chest pain not responding to therapy. On the second day, still fever with starting antibiotics, nail peroral, and all the measurement we were mentioning, but we had no response to therapy. On the first day, still fever, so we decide to scope him, and as you can see, we had a leakage. It means that the clip we placed after the myotomy that fell down, and there was a real opening making the first space was communicating with the second one, and everything it was swallowing, even the saliva was going in the chest. And this is why finally this was the only one in our unit that needed thoracotomy and washout and drainage. And it was discharged after 10 days and is living a nice life with no symptoms. The second case was this patient of 73 years with multiple comorbidities starting from the heart, atrial fibrillation, hypertension, but it was also diabetic with chronic obstructive pulmonary disease and also sleep apnea syndrome. He had this type of achalasia, and we perform an anterior POEM uneventfully, but see, on the second day, he developed fever, 38.6, chest pain, again, not responding to therapy. And when we scope him, we found again that the mucosotomy at the mucosal entrance was open with almost no clip left in place. And on the third image on the upper side, you will see that that one was the tunnel full of debris, pus, and horrible things, let me say. So we make a lavage and a toilet of the tunnel, and then in this case, we place a stent. So again, there's no only one way to go. And mainly we have case reports at the beginning talking about simple things like apnoperitoneum, but I show you from the video that is the simplest things ever, so you have not to think about that one. It's not nowadays recognized as a very strong adverse events, but then they had atrial fibrillation after POEM, and this is why we are not adding adrenaline in the solution we are injecting, but the main things is the esophageal leakage after POEM. So finally, we came out with this multi-center study of more than 1,800 patients to understand the real incidence of adverse events of POEM. And you see that the overall incidence is 7.5%, but then depending on the intensity, the severe one were only 9 on 1,826 patients, that is the 0.5%, and we had no reported fatal events, adverse events. The management was different. Most of the time it was with medical or conservative therapy, and only 4 patients, 2.6%, they need surgery to fix the adverse events they have. And also those incidental findings like apnoperitoneum, capnothorax, nowadays they are really not considered adverse events. Also, we can have in POEM different presentation time really at the beginning, in the first 48 hours or after 48 hours, or intraprocedural. Let me say that the intraprocedural, you have to understand and make a clear diagnosis when you have a complication inside before exiting and coming out from that body. You must do the best you can inside when you are in the tunnel, or even when you are closing the defect in the mucosal entrance. But then after the procedure, the main one are in the first 48 hours. Looking at leakage, there were 13, and 1 patient required surgery. That was the patient I showed you at the beginning, but all the others that were managed endoscopically or with the conservative measure. What about the severe adverse events? It was the 2 esophageal leaks, again, the one with surgery, but also we have 2 bleeding during tunnel, and I will show you a nice video, although it's not comprised in this series because it happened after we make this analysis with all the colleagues internationally. So what are the predictors associated to occurrence of adverse events in POEM? Of course, difficult procedure, that means in achalasia, sigmoid type esophagus, but also remember the experience of the endoscopy always make the difference. Really, at the end of this presentation, I think that I went a little bit more in, I used more time that was given to me. I'm sorry, but it is a difficult topic to say in a few minutes. I want to share with you my worst cases, that there are mainly two. One was a 82 years old male, and that had this lesion in the lower rectum. So I perform a standard, let me say, normal, regular ESD, was even not long. I put 45 minutes for this lesion. And as you can see in the third image, you have the bed of resection after the treatment. But then 4 days after the discharge, because I usually discharge this patient in the same day, he presented back to the emergency department with abdominal pain, fever, and blood proctorrhea. So the abdominal CT scan showed a perforation of the rectum with the anterior right pararectal abscess of around 5 centimeters. And it was really a nightmare, because when I scope him, you can see here exactly where was the bed of my resection, that there was no more muscularis propria, and everything you can see here is the abscess. I think, and I suppose that this one that is focused here is are the vesicles, the seminal vesicles of this patient, because we were in the anterior wall, it was a male, and then you also have urinary problem from that point of view. So we are really missing all the rectal wall in this side. We didn't know what happened. Maybe it was a small pararectal abscess that collapsed into the luminal side and destroyed the muscularis propria, or maybe it was the contrary. We had a delayed small perforation that can bigger and bigger and perform the abscess. We didn't know. But finally, I need to understand how to manage this patient. The patient was not deviated with any stoma, so it means that the stools was coming in this scenario. So I had to understand how to manage it and what to use it. And I want to show you that the first things I've done was trying to remove all the fibrins, and everything was inside to make a clean field and to try to let the body regenerate and try to heal this very big abscess. But my main concern was the stool that was passing in this area that was completely open. So finally, what I've done is the use of the endosponge. So again, you must know your devices and how to use it. Usually they are used for leakage in the anastomotical side, because in most of the cases, these patients are again deviated with stoma, but my patient was not. And you know that session by session by session by session, we were able to replace, because this is like a vacuum. So make a granulation tissue to try to regenerate and also prevent that the stools will go there. So I was placing the endosponge exactly in the area, in the design area. And after 5 months, this was just granulation tissue. We took biopsy just to be sure, but was just inflammation, but we reached the point. And the second and the really last worst case was a POEM patient, so 47 year with a type of achalasia. When I operated him, it was a 8 on 12 ECA score. I did an anterior POEM, and you know that on the night, 8 hours after procedure, he had a lipotemic episode with sphincteric release, and the blood test revealed a drop of hemoglobin from 16 preoperative to 10.7, but there was no hematemesis, there was melena, there was no clinical sign of active bleeding. So I immediately make a CT with contrast with oral contrast medium. And here you can see that we have a submucosal hematoma on the esophagogastric junction. And if you look here, this is the gastric fundus. You have a mucosal gap in between the submucosal hematoma and the gastric fundus. So I said this is a big hematoma inside the tunnel. And this is what I found when I scoped him. So the mucosotomy, the mucosal entrance was still completely sealed. But then here you have the hematoma in the submucosa, in the tunnel. And the problem is that when I look in the retroflexion, I found that this heavy and hard and big hematoma really break the tunnel at the end in the gastric side. So there was an opening closed only by the clot. So at the beginning I thought, okay, I will remove it and then I will try to close it. But then I said, stop a bit and try to understand. If you really remove it, you have a very big gap from the gastric side to the mediastinal side. So then I stopped and I said, let's see what will happen if I don't do anything more than giving PPIs, antibiotics, nil peros, and intravenous fluid. And after 2 weeks of this treatment, this was completely sealed. So if I ask to myself, what did I learn? The first thing is that got a complication, don't panic, breathe, really breathe will make the difference, and let your, your brain be oxygenated, and think of what? Think of the option, devices, treatment, your limits. Am I able to do this? Which are the colleagues that can help me? And then the second thing is that you are not alone. So if you need help, ask for it. Ask to anybody, from the surgeon to the radiologist, to even senior colleagues that know more than you. And the main thing is that not always aggressive measures is the way. Most of the time, the body knows how to regenerate and restore integrity. Thank you.